Evening, everyone. Sorry, thank you so much, Sammy. My name is Jamal Hayat. I'm a gastroenterologist at St George's Hospital, and just want to say thank you very much to Amanda for inviting me to come and talk to you about something that is very close to my heart, well, my esophagus or your esophagus, EoE. That was a great introduction, I think, from Sammy, which I think leads really into the treatment, having talked about how you diagnose and the symptoms involved in EoE, including more complex cases. So if that's all right, I'm going to talk to you about different treatments for EoE. So the first question is, should we treat EoE? So what we know is that if you have a diagnostic delay for your eosinophilic esophagitis, the more likely you are to get that fibrotic element to it, and you get more advanced disease, which can lead to a narrowed esophagus and strictures rather than just an inflammatory component. We also know that the longer you have had EoE untreated, the more likely you are to develop strictures as well with time in 10, 20, 30 years. We also know that if you do treat it, you're much less likely to have food impactions with follow-up. We also know that the more consistent you are with treatment, the less likely that is to happen as well. So what are our goals for treatments? So what we want to do is prevent this remodeling process from the inflammation that results from EoE, again, to prevent strictures, to prevent dysphagia, food impaction, and of course, improve quality of life. So those are our goals. So can we, and do we have effective treatment options? Well, the answer is yes. And we call them the 3 Ds. So we have diet, drugs, and dilatations. And hopefully I've just explain to you why we probably in most cases not do the 4th D, which is to not to treat. So I'm going to talk a bit about each of these different options now. So first of all, dietary therapy. So we can think about allergy-directed diets, an elemental diet, 6-food elimination diets, and a step-up diet. Another is a 2-4-6 diet. So I'm going to talk a little bit about each of these. And I think you've already had some webinars during February, which are specifically based on diet from our dietitians, which Amanda had set up. So, can we identify specific food triggers by allergy testing? I think Sammy's actually already answered that question, and that in the current form is actually not very good. They detect IgE with skin prick testing. So normally what we do is we put a bit of that allergen on your forearm, and we look for that particular reaction. But as EoE is more complicated than just that, it's not mainly based on IgE, certainly not at the later stage. It's not very good at predicting which foods cause and contribute to EoE. So it's the least favored of the 3 options that we have. There may be, and perhaps you'll hear or have heard a little bit about further options in this, which will probably be coming in the future, which look at food-specific IgG4 and other non-invasive biomarkers. So whilst at the moment we don't have specific allergy-directed testing, I suspect in the future we probably will, hopefully. So what about an elemental diet? Well, I mean, I'd have to say this is like taking a chainsaw to your diet and cutting out absolutely everything, all the allergens, and replacing it with an amino acid-based liquid formula, as you can see here. It's very effective, response rate of over 90% in both children and adults. So certainly it's the most effective of the dietary options, but of course it's the palatability, which is not very good, obviously excluding everything that you can eat. And of course this has significant social limitations, probably more so than we're all in for lockdown, not being able to go and eat. And as a result, there is of course complications with difficulties and adhering to it, certainly long term. So whilst it is very effective, perhaps not a first line for many. So what about the 6-food elimination diet? Well, I guess if the elemental diet is the chainsaw, this is probably taking a sledgehammer to your diet and excluding the 6 most common food allergens. So dairy, wheat, soy, eggs, nuts, and shellfish. So when this is done, you start off with a 6-food elimination diet, having had the diagnosis, and you would continue that for 6 weeks. At the end of the 6 weeks, then you would need an endoscopy to ensure that there is resolution of that inflammation. We can't just rely on symptoms alone, unfortunately. After that first follow-up endoscopy, The next steps would be to sequentially reintroduce particular foods, and at each occasion when you do that, to have another follow-up endoscopy after 6 weeks. And as Simon was saying, air allergens and food allergens aren't able to predict via skin prick testing which of these foods. And this was shown when this trial was done back in the States back in 2012. Often symptoms can reoccur within only a few days of reintroducing them. What we do find is that over 2/3 of patients have good eosinophilic reduction being on a 6-food elimination diet. The most common foods in this particular trial, which in the States, being wheat and milk. So those are the two most common. And as you can see, wheat in the majority of cases. So why do that? Why not do a more catered approach? So this is called the step-up diet and has been much more commonly used perhaps in the last year or 2 years, certainly in the UK. So if we think about the two most common food allergens involved in EoE, milk and wheat, why don't we do this at the start? And so what we do know is if you do that, you will get clinical, symptomatic and histological improvement in about 40% of cases. It's worth bearing in mind that in about 1/3, there will be an inflammatory response and a clinical response to both. So you may have both a milk and wheat allergy as well, not just the one. So with a 2-food elimination diet is about 40%. But when you want to step up to the diet, if that doesn't work, this is where it's difficult because it means adding more to that. And actually, lots of patients will probably not want to do that when you haven't responded to the initial diet. But if you do step up, you can get increasingly symptomatic and histological benefit from going on from a 2-food elimination diet to a 4-food and then a 6-food if need be. Of course, at each step, you'll have to exclude more and more foods, which does make it very difficult to adhere to. So what about medications which don't involve having to alter your diets? Well, PPIs, which have nothing to do with insurance, in other words, proton pump inhibitors, are probably one of the commonest drugs that certainly gastroenterologists and a lot of primary care physicians would have prescribed in the last 30 to 40 years. And you can even get them over the counter because of a very good safety profile. So why would a drug which we use to reduce acid be used in an allergic eosinophilic disease? So at first, it was thought that patients who are presenting as EoE patients were possibly a refractory form of gastroesophageal reflux disease. However, when Stephen Atwood and Professor Straumann came along, we found EoE. So by about 2007, guidelines were made which suggested that you would have to have a PPI trial to exclude GORD before you could be diagnosed with EoE. However, there were patients who were actually responsive to PPI therapy and didn't really behave like reflux patients, but more like EoE patients. So they were put into a separate group called PPI-responsive esophageal eosinophilia. However, they shared all the same hallmarks as EoE, in other words, clinical features, endoscopic, histological, and even genetic factors. Actually, what we think now is actually they're all part of an EoE subgroup and possibly with an overlap of reflux disease as well. Reflux disease is very common, so there's no reason why you couldn't have both. So why would PPI therapy be helpful? Well, actually, they have been shown to have a mild anti-inflammatory effect. It may also reduce the sensitivity of the esophagus by reducing the amount of acid that comes into it. And by doing that, help to improve the superficial mucosal barrier to allergens. So how effective are PPIs, if I'm calling that, in EoE? Well, they do result in good symptomatic improvement, but to a lesser extent do they reduce that inflammatory response. So it's important to realize that you may still have some symptom improvement at the start. If you don't have that histological improvement, you may still have an ongoing inflammatory process going on. So the most recent data in this is with the CONNECT registry, which is a pan-European registry of several hundred patients looking at eosinophilic esophagitis. Within this group, 600 patients had PPI therapy as first-line therapy. Less than half had a good symptomatic reduction or good eosinophilic reduction of less than 15 eosinophils per pound field, but with symptomatic improvement over 70%. What they found is that this was more effective in the inflammatory disease, so the earlier stage rather than the later stage of disease where you have more stricturing disease. There was some suggestion that it could be used for maintenance therapy as well. However, the maintenance period of 4 months is perhaps not very long. So what about side effects of PPI therapy? Well, Sammy actually gave a whole talk on this topic, and I've just got one slide to go through. And what I'll say is that there is low evidence of causality for most associated complications of PPI therapy. So you wouldn't be able to claim probably against many of these. So what I would say is that if there is some suggestion that you have low B12, low calcium, there's a risk of bone fractures or osteoporosis, which is commonly what patients do come and tell me. It's important to know, and particularly for the long term, the main thing is to make sure that there is an optimal dietary intake, calcium and vitamin D. If you're on an exclusion diet as well, that this is optimized with the help of a dietitian and to include your micronutrients. And one of the things that has been shown to be of greatest benefit for patients at risk of fractures is good, appropriate weight-bearing exercise, in addition to a good diet as well. So in most cases, it is safe to have a therapeutic trial. And it's important to optimize the dosing. Do you really need to be on such a high dose? Can it be stopped where necessary? And should it be switched to something else? So what about topical steroids or steroid therapy? Well, there is no role for systemic steroids in EoE. They are associated with side effects, and they're not any more effective than topical steroids. Now, for many years, we have not had a license and dedicated treatment for EoE. And so we've been using other alternative preparations we use for other diseases, such as asthma. So these come in viscous preparations, aerosolized, and others pumps. And more recently, in the last 1 or 2 years, we have had a dedicated form of steroid in the form of an orodispersible form. So these are the various devices which have been used to deliver these topical preparations. And we have Pulmicort Respules. These are often used in nebulizers. There are inhalers. So the meter dose inhaler is really the one I'd recommend. This is what's called an AccuHaler or a discus or a disc inhaler. It's very difficult to get the actual tablet which is in it out of this if you try and crack it open. And these are designed to deliver it to the lungs. So I'd probably try to avoid those if you can and use a meter dose inhaler. There have been many trials using topical steroids at various doses and at various different times between 2 and 12 weeks over the last 2 decades in both adults and children. And so the doses have varied, the different types and the length of treatments. What they have shown is that they reduce the inflammation. So this is the eosinophilic inflammation before and after therapy. So most trials have shown a reduction in that inflammation. They've also shown therapy and after therapy that there is a reduction in the symptoms, so dysphagia in particular. So looking at Pulmicort Respules with the Budesonide Respules, these come in liquid forms in 2 ml liquids. And the way to do that is to have a dosing of between 1 and 2 milligrams per day. And to do that, what you need to do is to have it in what's called a slurry, so a thickened consistency to try and deliver that medication to the esophagus to allow that topical distribution. So in the trials, and what we recommend is to use a kind of a sugar or sucralose solution such as Splenda and mix it into a thick consistency such as a slurry with the Respules. There are other ones as well, such as Neocate Nutra, and also Oroblend, which is commonly used in the pediatric population. And if you want a more natural remedy, honey is actually quite good as well. It has been shown to be as effective. These all allow greater contact with the esophagus. And the best time to take it is after meals. So what about the Fluticasone Inhaler? Well, it's like Bill Clinton, you don't inhale it, no matter what the pharmacist says. There are many times when I've issued a prescription and it's been taken to the pharmacist and the pharmacist says, no, this is not right, this is how you take it. So you don't want to inhale the inhaler. So one of the ways I say is to say, take a deep breath in, then depress the puffer and swallow it down and then exhale. And so the dose would be with a 250 microgram inhaler, 2 puffs twice a day. So about 1,000 micrograms per day. And you shouldn't eat or drink afterwards again for at least 30 minutes. So with this is a picture of the lungs, and this is the stomach and the esophagus. So when you do these preparations, unfortunately, you will get some in different areas. So you will get some preparation, swallowed, even with the nebulizers or with a meter dose inhaler, you will get deposition into the lungs. It's almost impossible not to. And also with the slurries, you will get a mix in that concentration. So you won't always get complete good topical distribution to the esophagus. So which one is better? Well, actually, this study showed that the viscous budesonide, the Pulmicort Respules, are pretty similar in efficacy to the Fluticasone meter dose inhaler. And they're both still very good as well. So I don't think it necessarily matters which one you do, but which one is the most practical. For example, for children, it's probably easier to use a Pulmicort slurry, but it's more practical, for example, if you're going out or if you're away, to have just a meter dose inhaler with you rather than having to mix up the different solutions. So what about the Orodispersible form? This is Jorveza, and I was very privileged and very happy, it was a great experience to be part of this trial at St. George's for the last few years. And I think it was great for my patients who were involved in it and to be able to prescribe it. Again, you take this after a meal. You have the tablets, which goes onto your tongue. You depress it against the top of your mouth, and it dissolves over a few minutes. And again, as it dissolves, you just take a few swallows as you're doing it, and then again, not to eat or drink afterwards, and avoid brushing your teeth. So how long should you take it for? Well, the initial trials around Europe started off at 6 weeks and then extended to a further 6 weeks, so 3 months altogether. What we found is that after 12 weeks, patients, well over 80%, were in both a deep histological remission of less than 5 eosinophils per high powered field. Dysphagia was less than 2 times per week. So there was a clinical and histological remission for most patients after 12 weeks. And this slide just demonstrates the histological improvement in different parts of the esophagus. So both in the proximal, the middle, and the distal esophagus, when you're on Jorveza, over 95% of patients had good histological remission, so throughout the esophagus. But actually, if you do stop it, you can get symptoms reoccur and that inflammation. We know that. And so this was an extension of this trial, which showed that after 48 weeks, continuing at the dose of either 0.5 milligrams of the budesonide, Jorveza, twice a day, or 1 milligram, this was effective at continuing and maintaining remission. There wasn't a great deal of difference. So you can see the red bar was the 1 milligram twice a day, and the green bar is the 0.5 milligram twice a day. Very similar between the two, maintaining remission at the end of the 48 weeks. However, if you're not on any medication having been treated before, the chance of not being in remission is very low. So you less than a 5% chance of maintaining that remission with its symptoms and histological inflammation at 48 weeks. That does suggest that you do need to have some form of long-term therapy. So what about the side effects for steroids, or topical steroids? Well, they are very safe. You can get candida, like an oral thrush. So it's a fungal infection of the throat. And that occurs in about 10% of cases. That often doesn't mean you need to stop treatment though, and can be readily treated for a few days with a topical antifungal. Nystatin is the name of the one which we normally tend to use. Most cases of this are asymptomatic though, and often found on follow-up endoscopies. Whilst I'm not a pediatrician, in children, there has been data to demonstrate with long-term use of high-dose asthma inhalers, there is some side effects of systemic steroids, such as impaired growth, decreased bone mineral density, skin thinning, bruising, and cataracts. So this should be taken into account, of course, for children. So what about dilatation? Well, I think Sammy had already quite beautifully demonstrated, even in a normal looking esophagus from endoscopy, how, for example, a dilatation can be useful. And of course, with strictures, they can develop and you can present with a food bowel impaction. So this is a picture of an esophagus with a food bolus stuck in there for one of my patients who very kindly gave me permission to put up these slides. One of my favorite EoE patients, I have to say. And so you can have a guess what you think this is. This was removed with what's called a Roth net, a bit like a fishing net. And this is what the esophagus looked like afterwards. And you might recognize this from some of Sammy's pictures from before. You can see these rings, which is what's called trachealization, where you get this fibrosis, which results in this rigidity. It looks like a trachea, which is your windpipe. That's why it's called trachealization. And the scope couldn't pass through this. So this was a stricture. So this had to be dilated. So this was dilated. The patient had already failed having proton pump inhibitor therapy, and she was put on topical steroid therapy. She didn't really get a lot of symptomatic improvement with the Fluticasone Inhaler, so we then switched her to the Jorveza. And following that, her esophagus went back to normal. So this is the bottom of the esophagus, and this is her esophageal body. So it looks like a normal, healthy esophagus. And from not being able to swallow a pea, this is what this is, it's a pea, she was eating shepherd's pie. So what about future treatments? Well, this is the cells of your esophagus, and this is the lumen of the esophagus. And so we've focused our treatments on what affects the luminal barrier. So food allergens come in here, so we can stop that by stopping the foods, acid suppressive medications and topical steroids. But what about the actual inflammatory process? Anti-inflammatory medications, which are often called biologics, so not things like ibuprofen. So we target different anti-inflammatory molecules. These are called interleukin 4, interleukin 13, and interleukin 5. So these are all involved in the inflammatory process of eosinophilic esophagitis. So these particular drugs have been used for lots of other conditions, atopic conditions like asthma and eczema. And so it was thought that they may be useful for EoE as well. Up until very recently, unfortunately, the trials have not showed a great deal of success, with perhaps a modest improvement to the esophageal inflammation, but less so the symptomatic improvement. However, more recently, there's been trials which are ongoing with an anti-interleukin 4 molecule called dupilumab, which is a weekly subcutaneous injection. That's how you take it. And this has been shown to have symptomatic and histologic improvement with phase 3 trials going on for 24 weeks, which has showed improvement in the eosinophilia, as well as a reduction in symptoms over a period of time. Benralizumab is another anti-inflammatory molecule against anti-interleukin 5, and we are currently recruiting for this particular trial, and this is going to carry on for just over 52 weeks of treatment. So in summary, the treatment is safe and effective. We can do this with the 3 Ds, diet, drugs, and dilatation. Which treatment one takes really depends on the individual, taking into account symptoms, endoscopic findings, and personal preferences. It's important to know that this is a chronic progressive condition, so without some form of maintenance therapy, often symptoms will relapse, and hence why it's important to follow patients up, ideally with someone who's interested in treating this condition. Okay, so thank you, and that's the end of my talk.
Thank you, Jamal. That was very, very comprehensive, and no mean feat to get that all into your half-an-hour slot. So thank you very much. Between the two of you, you've done a fantastic job of giving us a great overview from beginning to end. And the questions are streaming in. Sammy, you've done a great job of trying to answer some of them whilst we've been going through.